An armored car vanished during a routine stop. Carrying nearly $1 million, it was supposed to be impenetrable. Investigators didn't know if the driver was involved or if he had been ambushed. FBI agents and local detectives began to suspect a group of former law officers in the place. And their loving parents. It would take determination and high technology to track the robbers and make them pay for their son's crime. Cold-blooded.
Damn. on a certain complications. So if you have all the weapons, why go to war with one or two bullets? Always go with all the options. Now, grant you, when you have enough experience, you may get away and you may be able to see around and you can do a lot of things, maybe 85, 90% of the times. But we have to start thinking, what is the approach that can work in almost every case, whether complex or not? And even a simple case, like Ferris showed aneurysms, it doesn't matter where it is small or big, where it is high or low. You have to have the approaches that can widen all these windows whenever you need it. Sometimes you don't need much, and sometimes you need a lot. But even a small aneurysm, if you don't have enough approach or wide approach to see it, you're going to make it a complex, difficult aneurysm. And on the other hand, also, you cannot go in assuming that the case is going to be in your favor. Ferris showed some pictures. I got a lot of them to show, but he's already showed some. The third nerve is kissing the carotid. In another case, there is a highway between the third nerve and the carotid. And the incisura in different patients is different. You know, the same epidural hematoma, one patient will herniate, the other patient is awake and talking. Why? Because they have different normal anatomy. There is favorable anatomy and there is unfavorable anatomy. And if you do your case with the assumption that it's going to be good for favorable anatomy, even the most simple aneurysm can become a very complex aneurysm because the anatomy leading to it is not good. And I sometimes am surprised then when some colleagues will go up and show an approach and they say, this is the only approach I do. Well, I can tell you, this is very inexperienced and naive because it just tells you they've had problems because they categorize cases as difficult and not difficult. When you have the case that widens the approach, then the percentage of a difficult case number drops significantly. And that's what needs to be kept in mind in approaching problems. There's this competition now who can make a smaller craniotomy. It is ridiculous. We don't treat bone, we treat the brain. And it's time to get this out of our mind and start doing the right thing for patients. I have not seen any patients of mine complain about how long their incision is. Remember, people pay money to have an incision to do plastic surgery. And I don't think they mind having brain surgery with a larger incision if you can cure them. So the approach I use is a modification of the pterional approach. Everything is like a modification of pterional approach. And what we do is a wide opening so that you can mobilize the flap down. The zygoma is exposed. The reason for this is to take the temporalis muscle and drop it into this notch so that it's away. And when you look from this window, that's where I stopped doing the orbital part, the COZ part. Occasionally, I may take the zygoma, push it down if a patient has a big muscle and I want to look upward, because our view comes from here, not from here. If you're coming from here, you're really having a narrow corridor to get to that region. And then you have to have a wide temporal approach. And actually, Yazergil himself described it. He said, you know, when he did basilar, he opened more on the temporal side. He recognized it early. And the paper that Ferris described about Evandro, the pretemporal approach, he described the same, but the pretemporal Evandro did was the intradural type. And I know the last few years, he and I have been working together and on a lot of our courses, and he has started doing more the extradural approach because it really gives you a much more enhanced window in a way. And then the craniotomy, you can see, is more temporal. And once we get it out of the way, the next phase is really to expose the pretemporal extradural window, because removal of the clinoid and mobilizing the third nerve, and if you need to mobilize the fourth nerve, you have, all the options needed to widen your window. If you remove the clinoid, you get access to the posterior clinoid, you get access to the opposite P1, you get access to as low as possible. And if the window between the third nerve and the carotid intradurally is tight, then you release the ring and the proximal bands. I don't call them rings because there's only one ring, which is the distal, which is a dural ring. You can release all this and mobilize the carotid completely out of the way, mobilize the third nerve out of the way, and then you have a very large window looking at the interpeduncular fossa. And if you remove the posterior clinoid, you can go down. And if you need to go further down, then you mobilize the fourth nerve. And then you have all the options in front of you. Like in this case, third nerve, the PCOM, the basilar, that's the window. And then once you get this in front of you, you can immediately assess how to get full access to this point. Removal of the posterior clinoid so you can get access to the basilar, and then the PCOM cutting. And I have to mention that really this was also described and popularized for basilar by Professor Yazergil, and we published our experience with it. Like Ferris said, most of the time you can cut it proximal to the P1, P2 junction, but you can look at that paper to see it more. But it does enhance your view to where you can see this wide window. And if you notice here, there is a clip on the P1 on the opposite side here on the left, and there's a clip on the basilar. And this is where the PCOM was. It was obstructing the view. And look at the view you get when you do this approach. This becomes like a bifurcation aneurysm or an MC aneurysm. This is what makes this surgery less morbid, an enhanced approach, an enhanced view, and you have no blind spots. So this is the case, and you can see the opening, and I'll try to save time here. And this is then we open the sylvium fissure as described by Yazergil. And then you open the corridor going down to the third nerve. This is the third nerve now being opened.
5 minutes.
5 minutes. Okay. So I will only show one case, and this which will describe the approach, or maybe one more case to show a low-lying basilar. So this is the approach, and you can see how it's widening the window. And now you can see how much space I have. This is posterior. This is a clip on the basilar, a clip on the P1. And I can see all the perforators, and I collapse the aneurysm. And I have a full view of my clip going in. So let me skip this. This is the view you can get, and this is the result. Now, imagine this is a case which was sent to me again from another colleague, 35-year-old subarachnoid hemorrhage in 2011. Coiled and recoiled 2017. Now again recoiling. They want to have an opinion of what to do. Well, this is the original aneurysm. It is a shame that this aneurysm now is a malignant aneurysm. There's so many cases like this. And the publications show clearly that the problem is always coming from aneurysm that are wide and location at the basilar tip. They recur. So I will skip this. These are the examples that of problems that I see every day. Look at these. All these problems. This is a stroke in the brainstem. Another case like this, stroke in the brainstem. We cannot accept this and start doing a science out of the failure and then not talk about other options that can be used. We are lowering the bar a lot, like Michelangelo says, and we are really not achieving what we want to achieve. In surgery, a perfect job will give you a perfect result. And we just have to perfect the job in a way. So let me go to one case and then I will conclude. This is a case which is very low lying. You see it? And in this case, you can do a full transcavernous approach. And what we did is we opened the Meckel's cave. We mobilized third and fourth nerve. This is the fourth nerve being mobilized, third nerve. Carotid artery, sixth nerve. You see it's avascular. This is an exercise in anatomy. That's all what it is. And I will show you now removal of the petroclival junction. This is fourth and third nerve mobilized to the left. And look at the view you get for the aneurysm in this case. And that makes clipping of this aneurysm very quick and very easy. So I will skip and go to my conclusions. We treated about, it's more than 180 now with this approach, and or one of its variations. And this is the outcome of these patients. 83% of ruptured aneurysms in 3 months to 1 year are independent, 0 to 2 on the modified Rankin scale. You can see the outcomes. When it comes to the unruptured aneurysm, it's even higher, 89% on discharge, 95% in 3 months to a year, with a 0.5 mortality using this approach. And we had 3 which we couldn't clip, 2 of which had coils in them. 3 of our series regrew, which is about 1.5% compared to 30 and 40%. 2 of them we reclipped them. And the oculomotor palsy recovery is 98% if you know how to handle the optic nerve. And you know, when you master something, it becomes simple. If you go unprepared, you're gonna have problems. And I will skip this. This is Dr. De Oliveira's message always for success. Be passionate, determined, keep the courage, and have your inner sense and good judgment. And with Professor Yazagil, you know, he's always surprised how people shy away from trying something new. He puts it as courage. You have to have courage, but not reckless courage. It is judicious courage based on professional competence, which means you go and do your homework, you learn something, and then you come prepared, and then you can achieve better. So I hope for everybody listening, there's a lot of promise, and I am very optimistic, unlike a lot of people, about the future of microneurosurgery, because a treatment is not the best treatment when it works well in 80% or 50% or 90% or whatever. The best treatment is the one that always works and up to close to 100% of the times. It is wrong to play statistics with our patients to say, this is a good treatment that works in 80% of the times. Well, me, in my clinic, I'm seeing the 20%, the failures. And if I catch them before, they would have been included in my 95%. And that's better for the patients. So I'll stop here, and I hope I was useful to some, and thank you for the opportunity.
Professor Ali, Krish, thank you very much for your great presentation. It's a great pleasure to have you with us and sharing some of your experience. Would you mind to stop sharing your screen in order that
Okay.
Professor Lawton can share his own?
Okay.
Okay. Professor Lawton?
Yeah, can you hear me?
Yeah. Can you share your screen, please? And can you, I'm gonna turn on your camera because you're not in the window, or can you turn it on, please?
Yeah, it's says it doesn't allow me to because there are only 3 allowed to be on simultaneously.
Oh, I'm gonna check that. I'm gonna turn off all the cameras and then to let you go in, okay?
Okay, I see myself
There-
now.
Yes. And now just you can start your presentation.
And do you see my title slide?
Yes.
Okay.
Thank you,
Right.
Professor. I'm going to present you very fast. Professor Lawton is a neurovascular neurosurgeon known by everybody, President and CEO of Professor and Chairman of the Department of Neurosurgery, Chief, and the Neurovascular Neurosurgery in Barrow Neurological Institute at Phoenix. Professor, great pleasure to have us here with us, and thank you very much. It's all yours.
Okay. Well, thank you, Arturo. It's a pleasure to be part of your event, and appreciate the invitation. I'm going to just try my best to fill in the gaps that Ferris and Ali have left me. They're not a lot, but I just want to start with this slide just to show you that, people say that basilar aneurysm surgery is dead, that it doesn't happen anymore. That we're just not doing them. Well, look at this number right here. It's a significant number. I think that if you, as Ali said, stay determined and be courageous and don't give up, this is the kind of number that you can expect to see. It's really around 10% of my practice, and it's an important number. This is just a video to show you the territory that we are looking at. Can you see that video? Yeah, so the point of this is that it's very easy to see the anatomy. I think we're all pretty familiar with this anatomy here. We can see the basilar trunk, we can see the P1s, the aneurysm is clear, but what makes this surgery difficult is that we're not so lucky. We have obstacles in our way that obscure what we really want to see. This is what we really want to see, and we have things like the anterior clinoid, the posterior clinoid, and other obstacles that they get in our way and make our job of clipping aneurysms here more difficult. I'm going to give you my opinions about the approaches. I am a believer in the orbitozygomatic approach because one of the things Ali said is that if you have everything exposed maximally, then you can selectively choose what becomes relevant for the particular challenge. And I believe that when you do a good orbitozygomatic with a pterional, and I do this as a 2-piece because it gives me a good view of the orbital roof and the lateral wall for nice clean cuts and a really nice wide opening. When you have that exposure, then it gives you the freedom to go a little more anteriorly, go pretemporally, go subtemporally. You have essentially all of your windows of exposure open. I firmly believe that probably the most important thing in the basilar apex aneurysm is just getting a very good Sylvian Fisher split. So really knowing how to do this well, that protects the pia, that protects the veins, mobilizes them temporally, follows your opercular branches in, gets down to the trunks, really separates the frontal and temporal lobes completely. That is just so critical in opening up that corridor. One of the things that's really important is the anterocoroidal artery and getting to the crural cistern. Here's a picture of the anterocoroidal artery, and if you look, what it's doing, it's following the uncus around the medial temporal lobe. And if you follow this artery all the way around, what you're essentially doing is you're detethering the temporal lobe from the frontal attachments. And that's so important because it allows that temporal lobe to mobilize. It opens up the triangles that for us and Ali were talking about. And to get all the way back to the deep course of the choroidal artery, it communicates all of these various cisterns, the sylvian cistern, the carotid cistern, the lamina terminalis cistern to release CSF, and all the way finally down to this crural cistern and interpeduncular cisterns. This is a nice picture of all of the different little spots where you can get exposure. Here's your sylvian fissure slit. Here you find it that are on the under the temporal across the get pre-solved you can afford to mobilize. If there's 15 strong, you may not be able to sacrifice that, but you on that medial aspect of temporal lobe. Number 6, always good to check for pre-temporal artery or other temporal artery that might be tethering the temporal lobe. These are those trials that
Michael,
the carotid optic for because it's small.
Arturo, we are not able to hear well.
I think it's a local problem. We're gonna go back. Dr. Lawton's connection. We're telling him to rejoin our session. Just please hold on. Dr. Lawton's connection. We're telling him to rejoin our session. Just please hold on. Dr. Lawton's connection. We're telling him to rejoin our session. Just please hold on. Dr. Lawton's connection. We're telling him to rejoin our session. Just please hold on. Dr. Lawton's connection. We're telling him to rejoin our session. Just please hold on. Dr. Lawton's connection. We're telling him to rejoin our session. Just please hold on. Dr. Lawton's connection. We're telling him to rejoin our session. Just please hold on. Dr. Lawton's connection. We're telling him to rejoin our session. Just please hold on. Dr. Lawton's connection. We're telling him to rejoin our session. Just please hold on. Dr. Lawton's connection. We're telling him to rejoin our session. Just please hold on. Dr. Lawton's connection. We're telling him to rejoin our session. Just please hold on.
Professor Lawton comes back. If you agree, we can give you some questions for Professor Perez and Professor Christ that have been written in the chat. Professor Perez, you hear me?
Dr. Lawton's connection. We're telling him to rejoin our session. Just please hold on.
Lawton comes back. If you agree, we can give you some questions for Professor Perez and Professor Christ that have been written in the chat. Professor Perez, you hear me?
We can spend some time. Dr. Lawton's connection. We're telling him to rejoin our session. Just
Professor,
hold
can
on.
you talk us about we can talk about some questions for Professor Perez and Professor Christ that have been written in the chat. Professor Perez, you hear me?
We can spend some time. Dr. Lawton's connection. We're telling him to rejoin our session. Just
Professor,
hold
can
on.
you talk us about
Yes.
we can talk about some questions for Professor Perez and Professor Christ that have been written in the chat. Professor Perez, you hear me?
We can spend some time. Dr. Lawton's connection. We're telling him to rejoin our session. Just
Professor,
hold
can
on.
you talk us about
Yes.
we can talk about some questions for Professor Perez and Professor Christ that have been written in the chat in the webinar, so we can spend some time. Dr. Lawton's connection, we're telling him to rejoin our session. Just
Professor, can you talk us about questions for Professor Ravi's questions that has been written in the chat in the webinar, so we can spend some time. Dr. Lawton's connection, we're telling him to rejoin our session. Just Professor, can you talk us about how wide is Professor Ravi's questions that has been written in the chat in the webinar, so
the Lehman insulae and going down and widely exposing it, and then dissecting the temporal lobe away from the the lateral aspect of the carotid. Just like Michael mentioned, in that area you have to look at where the anterior choroidal coming out. Usually once you dissect the arachnoid, you can split it away from the anterior choroidal. What needs to be attentive to is sometimes there is a small branch coming from the proximal M1. And if it's a big branch and it is short and tight, it can give you problems if the aneurysm is high, even if you open the fissure. And this is where the real advantage of the transcavernous approach, because then you can go more inferior and lateral, because the full transcavernous approach is a combination of a pterional approach, of a pretemporal approach, and a subtemporal approach. You can get all these windows at the same time, and then you can avoid any blockage. Now, sometimes if it's a small branch and it's tight, you may want to coagulate and cut it, because if you keep more tension on the temporal lobe, it can avulse and bleed. So opening the fissure is a part of this operation, unless it's a very low aneurysm, then you really don't have to open the fissure with this approach that I do, because you go more fully transcavernous in a way. Can you still hear me?
Yes, thank you. There's another question about what tips can you give us to mobilize the third, the fourth, and the fifth nerves in the transcavernous approach?
Okay, the third nerve, you have to remove the clinoid, because that's where the dissection starts. And you come medial to the clinoid, medial to the third nerve. Over the clinoidal segment of the carotid, there is a little membrane. I call it the orbitoclinoidal membrane, which is part of the oculomotor carotid membrane. And you dissect it away from the third nerve. Now, then you follow the third nerve as it enters into the dura, and you have to cut tangential to the nerve. You know, Ferris mentioned you cut longitudinally, which is not horizontally or in a cross section to the nerve, which is true. But more than that, to be safe, you have to cut tangential in a longitudinal axis to the nerve, because even if you injure it, it's a surface injury, not a deep cut into it. And once you have to free it really from the square-orbital fissure all the way down to the brainstem, and this will mobilize the nerve. And once the nerve is mobilized, then if you manipulate it, it will not be injured in a permanent way. It will be just a temporary palsy. And that's an important concept to know. This is true to all the nerves. The fourth nerve is the same. I always like to use the example of a string of a guitar. If the guitar string is tight, you will have music. If it is loose, you don't have music. And in this case, music is injury. If it is tight, then the pressure, and we did publish a paper by one of my fellow, Dr. Basma, you should look it up. He did a beautiful job, studied the physics of the force and pressure relationship using a pressure gauge. If you put the same amount of force, how much pressure is exerted on the nerve if it is loosened versus tight, and it was much less. And that's how you mobilize it. Of course, you have to release it from the arachnoid. A word of caution, the third nerve, you don't want to manipulate it proximal to the brainstem. If you go to the lab and look at the anatomy, the nerve, when it comes out from the brainstem, it has like 4 or 5 little kind of fascicles. Try not to get there. This becomes a problem with superior cerebellar aneurysm. If they are large, they are digging inside the root of the third nerve. Try your best not to manipulate there because the injury is more permanent if you are more proximal. When you're distal, it can handle it better. The fourth nerve, you just have to follow it from the sphenoorbital fissure. Once it enters the tentorium, don't continue, stop, open the dura, look at it from inside, and then bridge the dura, and then you can mobilize it and remove the dura from around it. Sixth nerve, you don't need to do anything for it in the full transcavernous approach. You just have to know where it is, because you need to be medial to it when you cut the dura of the petroclival junction, so you can look down towards the pons of the brainstem. So, and the V1, V2, V3 are out of the way for similar approaches. And this, the beauty of this approach is not only used for basilar apex aneurysm, it's used to a whole list of problems like tumors of the hypothalamus, craniopharyngiomas, epidermoids, pontine lesions, mesencephalic lesions, chordomas, pituitary adenomas invading the cavernous sinus, suprasellar region. Last week we were 3 days in a row in the cavernous sinus, working up and down that corridor for 3 different lesions, 2 very invasive pituitary adenomas and 1 chordoma. So it is really it's a must that if you want to do good surgery around the brainstem and in the suprasellar region, that you know how to expose through the cavernous sinus. It's a highway that you're missing on. It's like you know, you're instead of taking a bicycle, you're taking a rocket to go somewhere. You're going to get there faster and in a shorter period of time.
Professor, there's another question, interesting one. What would be your biggest advice when you face an acute rupture aneurysm with a hemorrhage and an angry brain? What would prefer your approach?
Well, the first advice is angry brain is not a problem. The problem is an angry surgeon. So the first thing you need to do is to be able to control yourself and your nerves. This is what decides the outcome of any rupture. The most common cause of a bad outcome of a rupture is not the rupture, is what the surgeon does when the rupture occurs, how to handle it. A rupture is bleeding. You just have to make sure that you and your nurse have a plan, coordinated. You should take your nurse to the lab and make a rupture and show them how to deal with it. They have to be able to hand you one large suction. If you are holding the suction with the left hand, you take the suction with the right hand, the big one. You put it in quickly, and then you take another suction. They change it on the left. So I always have 2 suctions ready, and especially if you anticipate rupture. And then once you are controlling the blood into the suction, you are fine. The worst thing to do is to try to do things fast, to try to clip or to stop the bleeding. The first thing you need to do is to remember what was the last thing you were doing when the rupture happened. This is your best clue to what you should be doing. Then you know how to look for the rupture. Now, you should never get to a position where you are manipulating around the aneurysm and you have a rupture before you have proximal control. And this is a mistake that always done. And when I hear people saying they have 15-20% of the times intraop rupture, I'm shocked. I barely have, every year I may have one rupture which is a little early, and never before I get proximal control. If you look at the surgeries we do, in my, a lot of my fellows, you are here, Arturo and others, you rarely see rupture in my cases because we get proximal control. We cause a rupture ourselves. I have what I call a controlled ooze. I put a clip on the proximal and distal control, then I can manipulate. If it bleeds, not a big deal. A little bleeding and you put the clip, but you can see everything. And so an angry brain should not be a problem if you know how to handle the skull base. Always you can put a ventriculostomy to drain the spinal fluid, open lamina terminalis to release the brain. I have rarely, in the last 15 years, I have 1 or 2 cases that were so difficult that I couldn't advance the case and I stopped. But always there is a way to relax the brain. You can give diuretics, but you always have to go where spinal fluid is located. Sometimes it's impacted in the posterior fossa. You have to open the Lillekewitz membrane to drain the fluid, and so on. The most common cause of a very difficult brain that cannot be handled, in my experience, is usually a patient who had multiple bleeds, multiple hemorrhages. These patients have bled 3 to 4 days before, they stayed at home, they bled another time 24 hours before, they were not in good shape, and then next day they bleed again and they come in bad shape. And the other problem is when you have an impacted ventricular system, those are difficult brains. And this is common with pericallosal aneurysms. A lot of times they bleed in the ventricle in a big way, and then you have no CSF to drain because the ventricles are impacted. In those cases, I go through the corpus callosum and I evacuate the clot so I can circulate the spinal fluid for both ventricles if the patient is still salvageable. But again, if you follow the rules, if you know your anatomy, proximal control early, you should not have these catastrophic conditions and situation. And unfortunately, this is what led the endovascular option to become more prominent and to accuse the microsurgical option as being more morbid and not a good option. So again, be prepared, go watch somebody who mastered how to deal with a rupture, go to a lab. For those of you who've been to our lab, you have the Aboud model. Dr. Aboud has a beautiful model where you can simulate a rupture and we walk you through it and you learn it. You can do 20 or 100 ruptures in the lab before you do it, you deal with it in a patient.
Thank you, Professor. Another question about in which cases do you decide to sacrifice the PCOM to make some space in order to approach the basilar tip aneurysm?
Yeah, well, number one, the PCOM has to be small. The PCOM has to be smaller than P1. If it is larger than P1 or equal to P1, then I will not take it because then you will compromise the blood flow. If it's smaller, then I will take it. When do I take it? I usually assess it. I look and see the aneurysm and I see if sometimes I can see the neck, but if I am moving the clip in and out, it looks like I'm going to be more dangerous. Then I need more space, then I will coagulate and cut it. And usually you look for a perforator-free zone, most commonly closer to P1, P2. Now, I have 1 or 2 cases, I cut it at the carotid because there was a lot of branches all over except next to the takeoff from the carotid. It was 1, maybe 2 cases, I don't remember. And there was a couple, I cut them in the middle. I don't like to cut in the middle because you're close to the mammillary artery. that goes to the mammillary bodies. But then you can, most of the time, more distal, close to P1, P2 segment. So usually I assess it. Now, fortunately, when the PCOM is fetal, it is rare that you have basilar aneurysm. It's not as common, which is because obviously you don't have a lot of flow going into the artery because the flow is more taken by the fetal PCOM. So I have seen very few cases, maybe one or two, where there is a large fetal PCOM and the basilar aneurysm. It's rare.
There's a concern about what's your opinion about the hybrid neurosurgeon, about people who's training in an endovascular and vascular neurosurgery? What are your opinions about this?
Well, if you are busy, very busy in both, and that's the only thing you're doing, and you have a good training, I can imagine it being a possibility. But the trend now is not. I'm really not impressed by the outcomes of the hybrid idea so far. I can tell you one of the best hybrid surgeons that I know are the two guys who work with me, because they trained with me, they do the surgery, and they went and did endovascular. And when we have a case, if they feel nervous or they feel uncomfortable and they start thinking of endovascular and they show it to me and I say, well, why don't you do it and I'll help you with it. I think long term, this is a young person, it's a clippable aneurysm, and I can make you comfortable with it. And in this case, they decide to clip the aneurysm. And then next time they have the same case, they'll call me. They said, I have a similar case. If you're around, just come by. I'm going to go ahead and clip it. Why? Because they clipped it before. They gained from my experience, and now they can proceed with it. So in my experience, most of the hybrid colleagues have not been, real hybrids, to be honest with you. If you want to think of a hybrid who does both equally and as good, because a lot of them are doing less surgery in a way.
Muy bien.
But it's possible.
De sorpresa, como mínimo.
Okay.
Bien.
Thank you, Professor.
Oh, that was you calling.
You have the phone. Yeah.
Yeah.
No hay de que él ya está puesto. Muy bien.
Is Michael back?
I'm back. Sorry, I had no idea I was disconnected. Well, sorry about that. I think you missed the whole lecture. Well, the connection's been sort of on and off. I've noticed it come and go. Sorry about that.
Okay.
Well, you can, if you're asking questions, you can ask Michael this question too. They asked me about the concept of the hybrid neurosurgeon who does endovascular and microsurgery. And Michael has even experience firsthand with it. He can tell you his opinion. I gave them my opinion.
Yeah, well, I would have loved to have heard your opinion. I think I know it, and I think I agree with it. I'm a believer that you have to really subspecialize if you want to maximize your skills and reach the top of your expertise. I think you just need to be absolutely 100% committed. And I think if you try and do both, it's a dilution of your time and your focus. I think what has worked better in my practice is to build a team of excellent partners on all sides of the therapeutic spectrum. So, I have Dr. Albuquerque, I have Dr. Ducre. We have a wonderful team and a great working relationship. So,
Presentation on. Can you put
oh, yeah.
They really want to hear.
Yeah. So, what would you like me to do? Did you want me to go back to my talk, or?
Yes, if you don't mind, it will be nice for us. There's no problem. Sometimes these issues happen, and if you don't mind, we will enjoy to go back where you were in your presentation.
I think I got cut off pretty early.
Yeah.
No, take it forward now. No?
Maybe you were like by the Sylvian Fisher split technique, and you were talking about that, and we can take it from that, if that's okay with you.
You know what I think I might do? I think what I might do is start from the back and talk forward.
Perfect.
If I get cut off again, I think the stuff at the back is more interesting. I don't know. We can try that. All right. Let me start with this case here. Can you see this case?
Yes.
Okay. Maybe if we keep talking, I'll know that you're still there, or that I'm still there.
Yes.
Okay. So this is a young boy from Portugal. He presented at age 13 with a subarachnoid hemorrhage. Obviously, you can see what was done there. He was coiled, and the coil treatment worked. He was in a coma. He was in a coma actually for quite a while, but then he came out of his coma. On his follow-up imaging, you could see the aneurysm recurred. He was stent coiled at that point. And even after stent coiling, this recurred again. So finally, he got referred for surgical treatment. And I chose to do this through a transcavernous exposure because, as Ali has made the point, for ones like this, these giant recurrent thrombotic difficult aneurysms, you want absolutely every bit of exposure possible. So what you're looking at here is after the transcavernous exposure, anteroclinoidectomy, posterior clinoidectomy, dissecting the third nerve and mobilizing it laterally. You can see that the exposure is really quite good. This is the P1 segment. These are the tines of the stent seen through the vessels. And this is the neck of the aneurysm. We're looking at the front face. You can see our carotid ocular motor window has been maximally expanded with the transcavernous exposure. But this takes more than just good exposure. It's going to take some additional tricks. So I'm going to do a complete trapping of the quadrification. First clip here is going on the basilar trunk below the stent's tines. You can see nice preservation of those perforators. The second temporary clip is to occlude the P1 segment just at the level of the PCOM. This next clip takes care of the contralateral PCA. And this next clip takes care of the contralateral SCA. So now what we've got is good closure of the aneurysm. Now I have the confidence to actually go inside. And so this is an 11 blade. I'm opening into the aneurysm sac, and you can see thrombus within. Even if you've got a well-coiled aneurysm, there's still going to be about 70% of that aneurysm that's filled with thrombus. So by leaving the coils in their natural position and just doing this aggressive thrombectomy, you can see how I've dramatically changed the character of the aneurysm. It's now soft. I can now mobilize it out of the intrapeduncular cistern or fossa, and I can get my first fenestrated clip. This is the first clip going across the neck, and the purpose of this is just to kind of bring the neck back together again. And you can see I'm using most of what I've got from that clip length to get this in, but now with this next clip, I can keep going deeper. I can get that next blade piggybacked on top of the first and make it all the way across the neck. And with 2 additional clips, I can now close the fenestrations. So this is your classic Drake tandem fenestration configuration. And now the aneurysm opening is now reclosed. You can see our anatomy at the apex is nicely preserved.
We lost him again.
Professor Lawton, are you there? Professor Lawton? Okay. Professor Perez, do you hear me? Do you hear me, Perez? Professor Perez? No?
I don't think he can hear you.
Okay. Can you turn on your microphone?
Okay, now it's okay.
Okay. I don't know. I don't know if we had another connection problems with Professor Lawton, but can you give us some advice? Do you have you about the questions we have commenting in the chat? Which have you ever had any problem coagulating the bridging veins?
There are other brain veins that make it possible. The increase in the drainage through labé and trolar complex posterior. I don't have problem. I never have problem with coagulated bridging veins in the temporal pole.
Okay. Right now, Professor Lawton talk about a team, and what medical advices do you take care in the OR with your anesthesiology in order to keep a safe surgery?
Allow us to be much more complex. The vascular, I can't. Repeat, please. Repeat. Repeat, please.
What about the build? Do you hear me?
Now, yes.
Okay. The question is about when we make teams in our institutions. What medical advices do you take care with your anesthesiology? Do you hear me?
Can you hear me, Professor Fish?
I can hear you.
Okay, what do you think about the hybrid OR?
Hybrid OR.
Yes.
Well, there is one in the last maybe 10 years. I have one case which I thought it would have been good to have a hybrid OR, and my OR is about 20 meters away from the angio suite, so we just kept the patient intubated and moved it to the angio suite. Now, to do something at the same time, both endo and surgery, I usually am able to get proximal control. Most people who like the hybrid is because they ask for a proximal control in the neck or for the basilar. I have no problem finding proximal control, and I like to have proximal control myself. I like to have the clip myself. I did try one time an endovascular proximal control and ended up with a catastrophe. So one problem will kind of make you shy away from it. So, but I'm sure it will be helpful. Dr. Al-Mafti showed me a couple of cases of tumors he used it in. But for vascular, I don't see how often you can use it, especially for aneurysm surgery. It's maybe with time we can have more cases, but I don't like to have too many hands and too many places to control an aneurysm. We can hear you, Michael, now.
Yes.
Okay. Yeah, I don't think that trying to go through my slides is going to be very productive.
I see.
Yeah, I just want to take some question to you, Dr. Lawton.
Yeah.
What's your opinion about the hybrid OR? It was the question we were talking with Professor Chris.
Yeah, I'm not a huge fan. I think you decide which way you're going to go. You're going to either operate or you're going to treat the patient endovascularly. And I think people with hybrid ORs come up with some crazy notions of how to treat aneurysms and AVMs. And I think it's architecture muddling thought. And so you have to define your thoughts clearly up front and then stick with your plan.
Yeah, I agree.
Can you give us top 3 advices for the young neurosurgeons to master our practice?
So are we talking about with basilar aneurysms? Can you hear me?
Yes.
Oh, well, I think when it comes to basilar aneurysms, I would say number one is being very comfortable with Sylvian Fisher split. I think probably the most important thing you can do to improve your outcomes and your results with basilars is really splitting the Sylvian Fisher in a very clean and maximal way. The second thing I would say is being really comfortable with the little tricks that increase your exposure. And by that, I mean posterior clinoidectomy, anterior clinoidectomy if necessary, mobilizing the temporal lobe, and all those little tricks that open the window. And lastly, I think when you really have mastered all the other things, the third is the transcavernous. I think Ali has really made a great argument for the transcavernous approach for the really complex aneurysm. And I think it makes a lot of sense. And I think if you want to have your complete quiver filled with the right arrows, that's the third step.
I was enjoying watching that last case he showed.
Yeah.
Arturo, is this a question for all of us, or you have another question?
Can you hear me? Can you hear me?
Yeah.
Okay. How do you decide, or which are the main considerations to decide the left side or right side for tip basilar artery aneurysm?
For this question, for whom? We may ask Michael, because you know, he talked the least. We'd like to hear him.
So I go from the right side unless there's some reason not to. So the right side is the non-dominant side in the vast majority of cases. I think that if there's going to be any temporal lobe morbidity, you want that to be on the non-dominant side. It's a midline aneurysm, so most of the time that's fine. But the things that drive me to the left would be, you know, a fetal PCA on the right side that I think might get in the way, or the slant of the neck, some tilt of the aneurysm, other aneurysms that are on the left that might need to be treated. I think there's no reason not to go on the left because you very rarely get a temporal lobe problem, but I think it's good surgical hygiene just to stay away from that if you can.
Two more questions, Professor. What about your experience with perforator aneurysms or in fenestrated basilar arteries aneurysm?
Well, perforator artery aneurysms, I've seen, they're exceptionally rare. I've seen quite a few of them, and we've reported on these. They're very interesting aneurysms. They're basically fusiform distal dilations of the perforating arteries, and they're elusive. A lot of times we had one maybe 2 weeks ago where the angiogram was done. It was read as negative because you have to look very carefully at the delayed angiographic phase to actually see the aneurysm. When you find it, they're actually pretty easy to treat. You just go in and you occlude it. The problem is that they're very difficult to clip without compromising the perforator. So, a lot of times you end up having to take that perforator, but often these present with subarachnoid hemorrhage, and so you're forced to. If you feel like you can't, or if, let's say, you take it and you have a change in the neuromonitoring, then there are other things you can do. That case that we did last week, I was able to reconstruct a neck and save the flow. On other cases, you might do a clip wrapping where you get muslin or Gore-Tex and do a clip wrapping around these things. So there are options, but in general, they're rare and they just need to be trapped.
Okay, thank you so much, Professor Lawton. Dr. Ferris, can you hear me? Okay. I think we have some problems with the connection of Dr. Ferris. For Dr. Alikrich, what do you think about the subtemporal approach?
I think it is good for certain types of aneurysms if it is well kind of positioned, and in a case where the temporal lobe can be relaxed. In acute ruptures, you're really paying a price, and with the retraction of the temporal lobe significantly, especially if you have a very voluminous brain in a way. I have used it in some cases. It's very quick when you use it for the right case. I know you, Ernest Samy, and of course, Professor Drake has used it. Any approach you take, if you master it, you'll be able to manipulate around it, and you're no more operating with your vision, you're operating with your brain, so you can achieve a lot. But it has limitations, and if you look at Professor Drake's book, he clearly mentioned that the best approach is the one that will not only go subtemporal, but it will combine subtemporal, pterional, and more. That's exactly how he puts it. So he realized that he has limitations. If the aneurysm is very low, they had difficulty because you cannot get proximal control. If its aneurysm is very high, you need to retract the temporal lobe significantly, and that can be a problem. So, sometimes some surgeons feel like this is the best option in their hands. In that case, you have to do what's best in your hands, but be open-minded to acquire, new knowledge, and so you can advance or increase your options.
I use the subtemporal approach. I prefer the temporal approach in the basilar tip aneurysm, high reading, low reading, and normal reading. I use the subtemporal approach to have a lateral view. The relation between the posterior column perforating arteries and the neck of the aneurysm, and relation the talon perforating with arteries aneurysm.
You know, Arturo, I'll give you an example. Like I said, I use the approach. When did I use it? It was an unruptured case, a lady who is like in her 60s. She was skinny, and the aneurysm was not big, and it was just above the clinoid. And that's a perfect setup. It's projecting superiorly. That took like 45 minutes to do it because it has the ideal conditions. But again, like I mentioned earlier, this is a favorable anatomy case, but not every case is like this.
Okay, thank you so much, Professor Chris. We have with us Professor Juan Luis Gomez Amador from Mexico, from Neurological Institute of Mexico. Professor Gomez Amador, do you have any comment or question for the presenters?
Oh, yeah, sure. Good night. I want to congratulate for both your presentations. It was very enlightening. And I want to ask, back in 2001, when I was living in Little Rock, Professor Yashahel said to me, now you need to go to Parneski. At that time, Professor Parneski in Mainz, he was using the endoscope in order to reach some area. The axial view of a microscope was not enough to have a complete and integral vision, especially for some cases of aneurysm. So I have two considerations. First one, do you think there is a place for the use of some endoscopic view for some aneurysms? First one. And second one, talking about basilar aneurysms, there are some transclival approaches doing by the nose, endoscopic endonasal approach. Do you think there could be some case to be treated by this route? I want to hear the opinion of all of you.
Well, I can tell you that
Okay.
I don't think that there's a role to play for endoscopic clipping of basilar aneurysms through the nose. I've seen very good endonasal surgeons try to do this, and I've watched their videos. And what I take away is that by the time you do that exposure and you get your instruments in, you basically can put the clip on in one way with very limited flexibility in terms of your angle of application, all the different variables that make for a good clipping. And when you're that limited in that critical of an area, it's just not worth it. I think that the open surgical options are far superior. I think even some of the endovascular options are superior. So an endonasal approach is, I think, a technique in search of an indication there, and I just don't like what I see. I don't think it's a wise way for us to go. The only reason to do those is for cosmetic or minimally invasive advantages, and this is not an aneurysm where you want to sacrifice outcome for cosmesis. The endoscope is another story. I mean, I think that with some surgical confidence around the apex, you can manipulate tissues and get the views that you need. I don't think that an endoscope dramatically helps you with that because it comes in at many of the same angles, and it's such a tight space that it is equally difficult. I haven't found it to be very valuable in my practice.
Dr. Krish?
Yeah, I agree with Michael. You know, when you see a case, it's presented in conferences and it's successful and it looks nice, it's good visualization. Nobody can argue with success, but we have to be prepared for the more complex and for the mishaps, the problems that can occur. If you have a major problem with bleeding and your instrument cannot move except within a 1.5 to 2 centimeter width in a way, you're you're challenging yourself. And again, you know, if it's my head or for one of my loved ones, I would like, you know, Michael Lawton to be at his best and relaxed and can have many options except of one or two options. Then I would proceed. If it's my patient, I want to have the best full control options and not take any chances. Again, there may be select cases which are small. Like I said earlier, we have to make plans which work every time and safe every time. We cannot take chances. No matter how, you know, the concept has to be followed. You know, this is really important. There's a lot of things that can be done with an endoscope, but we have to be careful because, like Michael said, to use the endoscope by kind of forcing it to search for an indication, it may not be wise. Now, you may say, well, in my hand, it's much riskier to do it the cranial approach. That's why I'm doing it. If you're the only option and you think this is the best thing, that's fine. But there is relative terms and absolute terms. We have to look at the absolute terms, not the relative terms. The relative terms, maybe it's better not to operate at all. If you are in, unfortunately, one of the African countries, like I have some fellows who came, the best option is not to do anything in that case. That's a relative term. But is this the best option for the aneurysm when you have all the options available? The answer is no. So in terms of using an endoscope, I don't know if Juan was, when he was in Little Rock, if you remember, I had the Olympus microscope, which has an endoscope integrated, a nice small endoscope. I did use it, but I can to look around. But like Michael said, when you have the experience, you can see really with your brain the anatomy, and a lot of times you can put the temporary clips on and off, deflate the aneurysm, look around, and then you establish a three-dimensional picture in your mind. Then your clips become like they have eyes in front of them, and they have an endoscope on the tip of the clips because you can see with your brain, and the clip becomes, it has vision in a way. You can see with it. I do have a couple of cases where it was a difficult corner that I put the endoscope. I made sure that I didn't catch a perforator. I can see that, but that has to be really a very small endoscope that can look around the corner, and you have to be able to see both at the same time. In that case, that was a great microscope. It has picture-in-picture. You can see the endoscopic and microscopic picture through the same eyepiece. And unfortunately, they stopped producing those endoscopes.
Yeah. Professor Ferris, what do you think about it?
With Dr. Lawton and Dr. Christie, I have a nice view with microscope. I don't have experience with endoscope. I resolve the basilar, most of the case, my case, with microsurgery. I don't have experience with endoscope.
Thank you very much, and congratulations again for your presentations.
Thank you very much, Professor Juan Luis Gomez Amador. And thank you so much, Professor Christ, Professor Ferris, Chadad, and Professor Michael Lawton. It was a great pleasure to hear your lectures, amazing lectures. Thank you very much. We had attendees from different parts of the world, and it was a pleasure to hear you in this webinar. Thank you so much, and we hope to have you in the following webinars, and it was a pleasure to hear you. Thank you.
Okay, thank you, Arturo. Make sure next time the technical side is more under control.
Yes, Professor Chris. It happens.
Yes, We're going to work on that, and fortunately, we have seen a lot of COVIDius 19 from Professor Lawton social media. So we'll keep following you and see all your lectures over there. Thank you very much, and keep safe at your homes, and hope your families are okay. Have a good night. Thank you very much.
Thank you so much.
Thank you so much. Thank you. Thank you. Bye, Ali. Bye, Michael.
Bye-bye. Good
Very
to
much.
see you. Good to see you, Ferris and Michael. Good to see you again.
All right, good to see you guys.
All right. Bye.